Hello, my name is Julie Passarell. I'm the Assistant Vice President of Statistics here at Cognigen Corporation. Today I will be sharing with you an example of exposure response modeling using Phase 2 data. The title of my talk is Exposure Response Modeling from the Clarity Trial of Pimavanserin for Adjunctive Treatment of Major Depressive Disorder. I would like to thank my co-authors for this opportunity to share this poster with you today. The poster was originally presented at the 33rd Annual Psych Congress in September of 2020. The Clarity trial was a placebo-controlled Phase 2 trial of patients with major depressive disorder, an inadequate response to SSRIs or SNRIs. Pimavanserin was administered as adjunctive treatment. The results from the study indicated both a statistically and clinically significant improvement on the primary efficacy endpoint, the 17-item Hamilton Depression Rating Scale. In addition, significant improvements were also found for secondary endpoints of Clinical Global Impression Improvement Scale and Sheehan Disability Scale. Exposure response models were considered an integral part of clinical drug development and regulatory decision-making. Exposure response models were developed using data from this Phase 2 trial to assess the relationship between pimavanserin exposure and both efficacy and safety endpoints. The objectives of our analyses were the following: to characterize the relationship between pimavanserin exposure and efficacy endpoints, including HAM-D17, CGI-I, and SDS scores. Exposure response modeling of safety endpoints included Karolinska Sleepiness Scale and Massachusetts General Hospital Sexual Functioning Inventory scores. In addition, we looked at the incidence of select adverse events and exposure response relationships for headache, sedation, and somnolence. The study design was a sequential parallel comparison design. Patients were randomized at stage 1 to either placebo or pimavanserin adjunctive treatment for a total of 5 weeks. Patients who were administered pimavanserin in stage 1 continued on pimavanserin for the remainder of the study through stage 2, which was an additional 5 weeks of treatment. Patients who were randomized to placebo were evaluated at the end of stage 1 at 5 weeks in order to determine if the patient was a responder or non-responder. A non-responder was defined at week 5 as having the HAM-D17 total score at least 14 and the percent reduction from baseline in HAM-D17 total scores of less than 50%. These non-responders to placebo treatment were then re-randomized at the beginning of stage 2 to either continue on placebo treatment or be re-randomized to pimavanserin treatment. Patients who were identified at the end of stage 1 as placebo responders continued on placebo treatment for the remainder of stage 2. Sparse PK samples were collected at baseline and at week 1, 3, 5, 6, 8, and 10. In addition, samples were taken for patients experienced a serious adverse event or an adverse event leading to discontinuation. A population PK model was used in order to simulate individual exposure measures for use in exposure response analyses. We looked at Cmax, AUC, and C average. Average weekly exposure estimates between consecutive visits were used in models of efficacy endpoints and safety endpoints, KSS and MGH-SFI. For exposure response models of safety adverse events, steady-state pimavanserin exposure measures were used. Efficacy endpoints included HAM-D17 scores, which ranged from 0 to 52. Higher scores indicated more severe depression. CGI-I scores ranged from 1 to 7, and higher scores denoted less improvement in depression. SDS scores ranged from 0 to 10, and a higher score indicated greater disability. Safety endpoints KSS scores ranged from 1 to 9, and higher scores indicated more severe sleepiness. MGH-SFI scores indicated worse sexual functioning for higher values. We looked at the probability of the first occurrence of adverse events of special interest. The following process was used in order to develop the exposure response models for both safety and efficacy. Initially, exploratory data analysis was performed to understand the relationship between the different endpoints and pimavanserin exposure, and to better understand what types of models should be evaluated during the model process. First, we looked at the base structural model development, and we incorporated initially the placebo effect and then the drug exposure effects. We performed a stepwise covariate analysis, including forward selection followed by backward elimination. Any necessary model refinement was then performed, and finally, model evaluation was conducted using the industry standard of visual predictive checks. The results of the exposure response analysis for the HAM-D17 endpoint resulted in a sigmoid Emax time course model, including parameters estimating the baseline HAM-D17 score, maximum reduction in HAM-D response, time to 50% response, and sigmoidicity factor. The drug component of the model was a linear function of Cmax on Emax. Weight was a power function of T50. Body weight was a statistically significant predictor of time to 50% of the maximum effect, whereby heavier patients responded faster than lighter patients. No other covariates evaluated were significant predictors of HAM-D response. The exposure response model was used to predict scores at both week 5 and week 10. HAM-D scores improved steadily over time with both placebo and pimavanserin treatment. With increased exposure to pimavanserin resulted in an increased improvement in HAM-D scores. This figure provides the model predicted change in HAM-D17 from baseline versus weeks since first dose. The black line represents the placebo treatment, the red line represents pimavanserin 20 milligrams, and the blue line represents pimavanserin 34 milligrams. As you can see here, higher doses of pimavanserin are associated with more improvement in HAM-D17 scores over time. The exposure response model for Sheehan disability scores was also a sigmoid Emax time course model, including parameters for baseline SDS scores, Emax, T50, and the sigmoidicity factor. A linear function described the relationship between Emax and pimavanserin Cmax. Patients with higher baseline scores had more reduction or better response compared to patients with lower baseline scores. SDS response was not significantly affected by any other examined covariates. Similar to the HAM-D17 model, SDS scores improved over time with both placebo and pimavanserin treatment. However, there was more improvement with patients administered pimavanserin compared to placebo. Here you can see the difference in the values of the predicted SDS scores at week 5. For 20 milligrams were 3.01 and for 34 milligrams was 3.61 compared to the placebo response at 5 weeks of 2.15. There's a clear exposure-related effect for SDS scores. The exposure model for CGI-I was a proportional odds model with 3 additive components on the Logit scale: the baseline CGI-I score, a placebo time course, plus the drug effect. The placebo model was an inhibitory Emax time course model, including estimated parameters for both Emax and T50, and the drug effect model was an exponential function of pimavanserin C average. None of the covariates evaluated were found to be statistically significant predictors of CGI-I scores. We used stochastic simulations in order to quantify the effects of time and pimavanserin exposure on the cumulative probability of CGI scores. We were particularly interested in the probability of having a CGI score less than or equal to 3. For patients administered placebo, the probability of CGI score less than or equal to 3 was 37% at baseline compared to 85% at week 10. For patients administered pimavanserin 34 milligrams, there was an increased improvement at week 10 to 95% for CGI scores less than or equal to 3. The safety exposure response model for KSS scores was a proportional odds model with 3 additive components on the Logit scale: baseline KSS score, placebo time course, and drug effect. The placebo time course model was an exponential function of time, and the drug effect was a linear function of the average daily pimavanserin AUC. None of the covariates evaluated were found to be predictive of KSS response. We also used stochastic simulations to quantify the typical effects of time and pimavanserin exposure on the cumulative probability of KSS scores. This figure provides the cumulative percent of KSS scores on the y-axis versus week on the x-axis. We have separate panels for the placebo arm and the pimavanserin arm. As you can see, there is an increase in the probability of KSS scores over time in both groups. You can see here that there is a higher cumulative percent of KSS scores in the pimavanserin group compared to the placebo group, indicating an improvement in KSS scores on treatment with pimavanserin. At week 10, we have an improvement of 84% in the pimavanserin arm compared to 64% in the placebo arm when we look at a KSS score of less than or equal to 6. The Massachusetts General Hospital Sexual Functioning Inventory exposure response model was a simple linear time course for placebo effect plus a linear drug effect. This model only had 3 records collected for MGH SFI scores at week 5, week 10, and baseline. This simple linear function best described the model or the data for MGH SFI scores. This figure provides the change in MGH SFI score from baseline versus week since first dose. The black line represents the placebo treatment and the blue line represents pimavanserin 34 milligrams. As you can see here, there is an improvement in MGH SFI scores for pimavanserin treated patients. For the exposure response safety analysis using logistic regression, no exposure response relationship was found for any of the adverse events of interest. In conclusion, pimavanserin exposure response modeling showed a relationship between higher exposure and improvement in HAM-D17 scores. We found a consistent, statistically significant concentration effect relationship across multiple secondary efficacy endpoints. In addition, improvements in safety endpoints, including assessments of disability, improvements in symptom severity, drowsiness, and sexual dysfunction were detected. There was no correlation between pimavanserin exposure and select adverse events of interest. Collectively, the significant exposure-response relationships show that pimavanserin enhances the antidepressant response and may offer benefits with regard to sleepiness and sexual dysfunction in a concentration-dependent manner. Here's a list of references, and I would like to thank you very much for your attention today.